Conference. Today we've got a special event here. Today's session, we've got a plenary session, we've got a keynote speaker, and then we've got a poster session. So right now, without further ado, I would like to invite the keynote lecturer, Professor Piotr Buszman, who give a presentation and takes a lecture. Professor, please take the floor.
Thank you very much for this kind invitation, and it's a great pleasure and a great responsibility to give lecture to you, because this is always a great privilege. But most importantly, I can feel and I can taste, I can smell that you're really willing to hear it, and I hope this will be truly understandable and for you, and I will hope to highlight the need you will fulfill in the future together with clinicians. And I believe in the field I will present to you. I think it's extremely important, the multidisciplinary approach, and I will try to show you. So, the field of transcatheter valves has significantly evolved. It has been a major game changer in the past almost 2 decades now. And the field has shifted from feasibility, and by that I mean we shifted from whether it's possible to implant a valve through a catheter, through a minor hole in your groin, because we now know this is doable, this is feasible, and we're shifting now towards durability. So now we know that this valve can be implanted. It has made a significant a change in the field, especially for the patients. But now, as more and more patients are willing to get such a transcatheter valve instead of surgery, we're moving to the field to prolong the life of this transcatheter aortic valves, and this is the part of the biotechnological team, engineering team, which I will show you. Why the field of transcatheter aortic valve is important. Is it working? This is Mick. Mick is 84. Mick has released a new record and made a new tour, and that has been technically possible thanks to transcatheter aortic valve technologies. Almost 4 years ago, he was implanted with transcatheter aortic valve, and although he looks biologically younger, due to high surgical risk, he was not deemed operable for classical surgery with the sternotomy. So he was implanted with one of the first generation transcatheter valves. On the left, you can see the balloon expandable valve with the bovine leaflets. This is Sapien Edwards 3, the benchmark, the golden standard from the Edwards Life Sciences. And on the right, you can see the Evolute valve, the self-expandable nitinol frame, made from porcine pericardium. The right on the right, it's self-expandable, but it's also supraannular. So that means that the leaflets of the prosthesis are being sewn a little higher and being implanted a little higher than the native valves, and that gives us a little more space in the aortic annulus. And although these valves seems to be comparable at 3-5 years, there are now some signs that the valve on the right can provide a little superior outcomes, because basically it provides a little more space for the flow of the blood because it's supraannular, and we're putting the valve supraannulary. So these are the first generation valves, and we're getting now into the field of second generation valves. The second generation valves is evolving into 2 directions. The direction number 1, it's its architecture. Obviously the architecture of the leaflets, the architecture of the stent frame, and the architecture of the materials sewn onto the stent. This is on the left, this is Dura AVR, which I'm going to talk about you later. Please Notice how big opening orifice area it has. So much higher than the previous valves. And the second field where the field is going is basically novel materials. So they can be either biological transgenic, which basically should prolong the life of such a valve, or because of the development in the polymeric field, polymeric valves. Here we see the Foldex valve, which is polymeric, and this is our inflow Polish valve, made from polycarbonate valve that is of the polymeric material that is put on a stent with the electrospinning technique. This is basically the implantation of the aortic valve. You can see the valve is significantly calcified. The valve basically does not allow blood to go out into your body and does not allow to provide the cardiac output needed. So basically the transcatheter aortic valve technology is putting a valve through a catheter, through a balloon or self-expandable, this is actually Edwards, into this valve. So relatively simple, but not that simple, and thanks to technology this has been possible. And it has made a tremendous change in the life of the patients. So imagine a pancreatic cancer that currently gives you an option to prolong your life by 60-70% up to 10 years. This is the change that has been made with transcatheter aortic valves. The patients who were previously not eligible for surgery and were basically dedicated for palliative care that would usually survive 6 months up to 1 month now can easily live up to 5, 6, or even more years in the subgroup of patients. So as you can see, the difference in mortality hazards ratio 50%, we decreased mortality of 50% when compared to standard of care. So not only in the patients that were inoperable or high risk, but it turned out that transcatheter aortic valve replacement is even better by 56% in terms of death, stroke, or rehospitalization when compared to classical surgery. So even in lower risk patients, transcatheter aortic valve are better, are improving their life and improving their quality of life over long term. How does it look when compared to other therapies? So we know antibiotics, we know sepsis, and as you can see, the hazard ratio of antibiotics which decrease sepsis is 65%. So this is similar to transcatheter aortic valve implantation. When you look at the pneumonia, 70-80%. So as you can see, the introduction of transcatheter aortic valve has been a tremendous change in the field of medicine that is very many times seen before. And this is the pioneer who did it, Dr. Alain Cribière, who unfortunately passed last year. His idea, he did it in 2002. He basically has sewn sutured the leaflets, the bovine pericardial leaflets, into the stent, and decided that he wants, this is the patient that was in a cardiogenic shock due to severe calcific aortic stenosis without basically any treatment option, and he did it more than 20 years ago, almost 25 years ago now, and it was at that time a tremendous success. Unfortunately, I think that due to regulations, I don't think that would be possible currently, and even due to ethics, but thanks to this pioneer, we are where we are now. And how does it look in Poland? In Poland, we perform 5,000 procedures per year. And what we do think is that patients require, at least in Poland, 11,000 procedures. So we need twice than that. So we need those technologies to be better and most importantly, more cost effective. And as you can, and as I've shown you, this is not a technology that is basically supplementing your diet. It's a procedure that saves your life tremendously, and yet it's a huge unmet clinical and public need. And on top of that, we can we are in a place where at least 9 out of 10 severe aortic stenosis are underdiagnosed. So as you can see that in Poland we would need at least 100,000 TAVIs per year to save these lives, and unfortunately due to limitations, still limitations with our public service and National Health Funds provider, we are still a little low, much low. The demand is much bigger than we're implanting. So 5,000, 11,000 needed, and even more is required. And of course, because such a tremendous success, more than a couple of 100,000 TAVIs are implanted per year, it is a huge business opportunity. As you can see, the market at 2030 is growing significantly, and as you can see in the 2032, it will be worth $22 billion around the year. So because of such a high cost-effective and highly effective technology, it's interesting and it's a tasty piece of cake for business that basically we can provide these technologies for the patients as the clinical need grows, because we grow older. The older we are, the more calcific aortic valve stenosis there will be. So what is the challenge? We know that we can implant it, that it is durable, and what is the challenge? The challenge is to implant these valves into younger patients because patients don't want surgery. Currently, it is recommended for patients 75 years and older who are at even low risk of surgery. Recent guidelines has shifted to 70 years or older, but we have patients 30, 40, 50, 60 years old that say, we don't want a surgery, we don't want an open heart surgery, we don't want a blood-lung pump, and basically we want to go home next day, because after transcatheter aortic valve replacement, you can go home next day. So the issue is that these valves, they may deteriorate, they may fail due to structural valve deterioration, due to calcification, and due to thrombosis. So when we look at this data, at 5 years, the bioprosthetic valve failure is somewhere around 10% in transcatheter aortic valve replacement, and somewhere around 14%. So those transcatheter valves, they tend to deteriorate a little less when compared to their surgical counterparts. Obviously, this is not statistically significant, but as you can see, as the technology, as the biotechnological processes grow, there tends to be a significant increase. But still, this is a challenge. Why is this a challenge? Because if we implant a valve in a 60-year-old patient and we give him 10, 12 years, that is basically not enough. Because after 10, 12 years, he will need another prosthesis and another prosthesis after another 20 or 30 years. We want to prolong their lives at least to the estimated average lifespan of a healthy person. So if someone is 60 years old, we want to give him at least 30 years more. So if we implant another and another, that becomes more difficult, that becomes more risky. So what we want these prostheses is we want them to become more and more durable. And that is the part where engineers and biotechnologists and researchers come into place. Recently, we are in the progress of publishing a very important paper, a statement of European Society of Cardiology, how these new valves should be tested. And they should not be tested only for their limited time durability, but this test should provide surrogates of long-term durability. And here is the place, here is the region where multidisciplinary teams come in. As you can see, one of the very important functions of the valve and one of the very important surrogates is the effective orifice area. As you can see, this is the Dura AVR valve. It is the effective orifice area in centimeters square. It's much bigger when compared to competitors, and that provides lesser gradients through the valve. So the bigger the opening, basically, the better the valve. Okay, very simple. But the bigger the opening, the lesser gradient, the lesser flow velocity you're getting through the valve, and basically that will help. That should translate into lesser valve, structural valve deterioration. But on the other hand, if the valve opens this high, there is a caveat, because if the leaflet touches the frame of the valve, it may cause tears and it may cause injuries. So we really need to balance between those two, and that's where the architecture of the stent frame, architecture of the leaflets kick in. I hope this works. There you go. This is a Dura EVR. As you can see, a very high opening. This is the Sapien tree. A little bit of pinwheeling inside. Pinwheeling is when these leaflets come together and they wheel. We don't want that. That's even in the ISO guidelines, that it should be limited. So number one, the Dura EVR, you can see it's opening very widely, but it does not touch the struts. That is quite important. So we test those valves in the pulse duplicators. This is the first stage where we test these valves, and which help us to develop a better architecture of the leaflets and better architecture of the stents, or even suturing. As you can see, the lesser suturing, the better. We want sutureless valves. We want these leaflets, those commissures, be implanted directly to the stent frame without possible sutures here, as they limit the opening orifice area. Numerical flow modeling, this is something that is becoming really important, because we can predict already the outcome, whether the flow is going to be laminar, turbulent, or coaxial, already in the numerical computation, numerical setting. We use the experience of the Silesian Polytechnic already with our valve that helps us to predict whether the flow will be turbulent, or so you can see here example of bicuspid valve. As you can see, a lot of turbulencies, and tricuspid valve where of the native valve where the flow is much better, and this can also be translated into the valves. The very new, not so new because it was used in aerodynamics, and something that can be used for evaluation of the flow through the valve, and you would probably teach me better about this, is the particle image velocimetry. So again, we want to see if this would be the valve. We can evaluate the how the particles move, whether the flow is turbulent, whether it's laminar. We want it to be laminar, and we want it to be coaxial. We don't want it to hit the walls. We don't want it to be turbulent. Turbulent flow causes thrombosis, calcification. What we want is a laminar flow that is coaxial, goes directly into the aorta. And subsequently, this can be translated and this can be tested in the in vivo setting. As you can see, this is the MRI, which basically is a PIV in vivo. And in our preclinical laboratory, we can also test it, and we evaluate how these flows go through. As you can see, the velocity is, in this case, this is a natural valve, this is native valve. This is what we want to get. The velocity is pretty much everywhere less than 1 meter per second. The latest technology allows us also to predict the outcome of the valve implantation completely in the simulator, in the computational simulator. So we can choose not only the positioning of the valve, whether it should be higher, whether it should be lower, or the type of valve, whether self-expandable or balloon expandable. This is the software that is already approved by FDA. We are trying to bring it to Europe. This is actually used in a clinical setting, but why don't we use it in a preclinical setting where the new valves are developed and help predict the outcome, at least acute outcome, and chemodynamics soon after implantation. In our preclinical research center, obviously, we evaluate long-term biomechanical response. So basically, all that I've shown you before is something that can be done on a bench in the computational models. In our preclinical laboratory, we are shifting also a little bit from animals to also bench models, but still the animal models help us predict long-term biocompatibility. In the aortic banding model, we implant these valves and we evaluate their biomechanical response at 6 months or even 12 months. Previously, that has been not possible because there were no calcification of the aortic valves, no disease in the sheeps. So every valve you would have implanted would certainly either flip or drop out from the native annulus, and that caused huge mortality, 80% model related, not related to the valve. With this model, we helped to develop the methodology to assess long-term biomechanical response. Our mortality is now less than 10% at 6 months. That is caused by these models. And we can definitely evaluate what we want to predict in a clinical setting. Here you can see this is the balloon expandable valve in pathology, and after 6 months you can see some calcifications in these valves, in the biological counterparts, but we also use in vivo technology in micro-CT where we can evaluate the structure of the stent, where we can evaluate the thrombus deposition like HALT, or basically microscopically we can evaluate the, for example, the pannus. So we can easily translate and correlate the simulation and the bench models into the biological response, everything that is done in the preclinical setting. Structure and architecture, that's number one, where we can improve our field. The second one is obviously the material. As the material field development grows significantly, especially with the polymeric valves, we developed a polymeric valve and a biological valve that is made of the transgenic material. So basically it's the material, it's the transgenic material that that is breeded and that is harvested from swine that are transgenic. They have a mutation, alpha-galactoside deletion, and we believe that they will be more durable, that they will not calcify, just like the normal biological counterparts. Therefore, these technologies, number one, they should, their goal is for to be implantable for patients that are younger, even 60, 65 years old, especially with polymeric technology. And number two, there will be, we predict, we hope they will be more available, as the polymeric valve is basically electrospinned on a stent, and that can be done in one clean room, in one core central core laboratory, where you don't need all the biotechnological processes, tissue harvesting, animal breeding, animal harvesting, and all the procedures that are necessary to get a healthy and high quality biological material. So through electrospinning of the polymeric material onto the valve, we omit a lot of biotechnological phases. So therefore this valve is, let's say, it can be much cheaper, but on the other hand, because it's a polymeric material, we hope that it will be much more durable and it will not deteriorate just like the biological material, and that can provide significant benefits for the healthcare. That's for patients. We believe that this valve will be more durable for 20, 30 years. The patients will recover faster because our system is much smaller. It's only 14 French. And that will, because we believe it will be more cost effective, will be more available for the patient. And as you can see, the unmet clinical and public healthcare need is huge. So the way we do it is we wove it through electrospinning on the valve, and then the polymeric material is being put inside, and then it's being sutured to the stent frame. That's the polymeric solution. I've already talked about biological valve, where we hope to introduce transgenic valves. We tested these both in a preclinical model. What we are concerned with polymeric material and what we are concerned with any material that is not biological is obviously the biological response. And with polymeric material, just like with polycarbonate valves that are surgical, you need to have anticoagulations because otherwise they will thrombose. Thanks to this new material, this polymeric material, we did not see any significant amount of thrombus in the animal model, but on the other hand, we saw a very good hemodynamical performance of this valve with gradients even decreasing over time. But what we did see is the thin layers of cells on the polymeric valve, and we do believe this needs further investigation. We do believe that this could be endothelium. So if the endothelium could cover the polymeric material, then we can definitely skip the antithrombotic therapy for such a polymeric valve, which would be a huge breakthrough, because in the surgical polycarbonate valves, you do need antithrombotic therapy. Our biological valve has also shown excellent biomechanical, biological response. However, we did see some scanty calcification on this valve, just like expected with the biological material. These were only scanty, but this kind of proves our thesis that the biological material can calcify, whether polymeric cannot, and that is a huge promise and a hope that they will not deteriorate in the clinical setting. This product is covered by multiple patents, including US, so we hope that in 2027, and we do believe that in 2027 we will have the first in-human implantations and commercialization in 2030. So my take-home message for you as engineers and as students is that we basically need to work as soon as possible as a multidisciplinary team on the development of these valves, because we bring the ideas, we show you the needs, we show you unmet clinical needs, and you basically provide solutions. Or sometimes we have an idea of a solution, but it's you who need to implement it through engineering, through design, through architecture, through material engineering. So the future TAVR technologies will focus and are focusing now on long-term durability. We managed the stage where we wonder whether it's doable. We know we can implant them. The next stage is we want to make it more durable. And that is through evaluation and development of better stent valve leaflet architecture, to careful evaluation of fluid dynamics, that's computational fluid dynamics, that's PIV, but also novel materials, polymeric or biological transgenic. And multidisciplinary mathematical and bench modeling will be crucial for this development. Thank you very much.
Thank you very much for the outstanding presentation. And now the presentation is open for the discussion, or are there any questions? Actually, I've got one. You mentioned the software which was used for evaluation of hemodynamics. And I'm wondering, since I know that you've performed these tests as a bench testing in the lab, as a regular testing in the lab. So I'm wondering about the coefficient. I mean, how, let's say, the applicability of the software, how it covers reality. What's the percentage of this one? Is it because you mentioned this is FDA approved already? So I was wondering.
It's the simulation for implantation, but not yet the hemodynamic flow. So that's a very good That's a very good question. So this software allows us, for example, because number one, we take patient CT, so we take the real scan of a real patient, and basically what it allows us during the procedure, many times, often, we think whether the valve should be higher or lower, or whether we should choose self-expandable or balloon expandable valve. And because this software resembles the calcification in the aortic valve, which are very rarely representative, they're always different. The eccentricity, concentricity, sometimes you get a big piece of calcium chunk in one leaflet that goes into LVOT. So this is something that we can very hardly predict. And what we're concerned about are the paravalvular leaks. So this software does help us, number one, to position the valve, and number two, choose the valve. So There are not many validation data yet, because it would be extremely difficult to do it, but there's a randomized trial ongoing with or without the software. And basically after this randomized trial is finished, we will know whether this helps or not. If this helps our judgment. So, but the results are going to come out soon. Obviously, the subjective feeling is that it's helping and it's better, because, for example, we can predict the most fearable complications like left main coronary occlusion if we go too high or we choose the wrong valve, and we can predict the paravalvular leak with which we're still not able to do more currently, because we either predilate or postdilate, but the choice of the valve which has more radial strength can support this and probably make these leaks lesser. But this is in the stage of investigation.
Okay, thank you very much. And actually, for me, you know, while you're describing it, the very basic challenge, you know, from the engineering point of view, is the stiffness of material, because you mentioned the classification, the different rate for classification, and it means that for sure it needs to be adapted to individual patients. However, for sure, since the case statistics, it is, let's say, physically impossible just to apply it directly, but nonetheless, okay, I believe that, you know, after some let's say applying for even AI models or something like that, it could be improved, so in a very good direction.
So where we are now is we should basically, the big field of research is how do these flow dynamics PIV tests translate into healing of the valve. So basically what we can do still together, and what we're trying to do, is we have this animal model where we see scanticalcification thrombi, and we should correlate it with the fluid, for example, fluid dynamics or geometry of the valve, of the opening orifice area. How does this translate into the biological outcome? Because if we get this done, basically we'll be able to predict long-term clinical outcomes, and the CFD, PIV will basically be a great surrogate of long-term durability, which we do need now, because every physician, every regulatory body is asking for it. Because now they're asking, okay, you can implant it, you've done 200 million tests on pulse duplicator, 200 million cycles, but how does this translate into biological response? We don't know. And we need to give them that, for example, and probably it can limit the clinical trial, limit the duration of the clinical trials, because we cannot prolong the clinical trials up to 2, 3, 5, 10 years, because that makes no sense. The patients need the technology, and in such a way we would need to, that would slow down the process of innovation and bringing patients help. So we need to find those surrogates, computational flow surrogates, that will basically translate into better clinical outcomes. For example, we know that the so-called pinwheeling, where the valves is twisting inside, that's something that increases the deterioration of the valve. But I believe if we find more such a surrogates, it will be great.
Okay, so I'm really impressed with your work in general, because this is something what you do. Let's say on the real field, in terms of a surgical operation. So congratulations.
Thank you very much.
Are there any other questions? If no, once again, thank you very much.
Thank you very much.
And now I believe that we move to another session, another part of this session, and I would like to ask Professor Czajkowska to chair this session. There are 3 co-chairs, so please take the floor.
Good morning, ladies and gentlemen. I am really pleased to open the poster session. A special welcome to our young researchers who will present their posters today. And the session has a form of a competition. And let me introduce the jury. It consists of Professor Szewczenko, Professor Wolański, and me. We will assess and evaluate every paper, and the best paper will be awarded during the closing ceremony. So the time slot for a single presentation is about 3 minutes, and all the presenters are asked to keep it. So welcome once again. Hopefully you will enjoy the session. And our first presenter is Ms. Mirella Kluza, our PhD student. The floor is yours.
Good morning, everyone. My name is Mirella Kluza. I am representing the Łukasiewicz Research Network, Krakow Institute of Technology, and I am also a PhD student of the Silesian University of Technology. And today I would like to present to you the development of a virtual simulation platform for the ARMCARE assistive manipulator in Unity 3D. Assistive robotic manipulators are increasingly employed in home care to support patients with limited mobility. However, their development and validation often require the costly physical prototyping. This study addresses that challenge by proposing a virtual simulation platform for the ARMCARE manipulator developed in Unity 3D. The objective was to create a scalable and interactive environment for simulating motion trajectories and evaluating usability in home care scenarios. So the simulation process began with the creation of a high-fidelity 3D model of the ARMCARE manipulator using Autodesk Inventor. This model was then optimized in Blender for compatibility with the Unity engine. Within Unity, a virtual home care environment was constructed to replicate the real-world operating conditions. A control algorithm was implemented in C#, enabling the precise coordination of the joint movements and spatial orientation. And additionally, an interactive graphic user interface was developed to allow the manual control of individual joints, facilitating the real-time testing and manipulation of the motion sequences. Okay. The resulting platform supports the simulation of the manipulator's kinematic behavior. It enables the visualization and validation of predefined motion trajectories and provides the robust framework for testing under controlled conditions. This approach not only accelerates that development cycle, but also opens possibilities for future research, including the automation of patient care tasks and integration with advanced technologies such as virtual reality or the digital twins. In conclusion, the study demonstrates the potential of simulation-based methodologies in advancing assistive robotics for the healthcare applications. Thank you very much.
Thank you very much for the presentation. The next speaker is Ilona Karpiel.
Good morning, everyone. My name is Ilona Karpiel. I represent Łukasiewicz Research Network, Krakow Institute of Technology. I wanted something to speak about a study which I was conducted last year. And the first, I briefly speak about what is ICG. Impedance cardiography is a non-invasive, cost-effective method for conditions monitoring of hemodynamics parameters. Despite its potential, its clinical use is still limited by signal variability, noise, and the lack of standardized data sets. The aim of our study was to compare selected approaches to ICG signal analysis, focusing on the detection of characteristic points and the improvement of stroke volume and cardiac output estimation. We applied two approaches. The first involved filtering the signal, segmenting cardiac cycles, averaging them, and identifying characteristic point based on known physiological landmarks. The second approach used well-vet decomposition to better separate signal from noise, followed by characteristic point detection. In both cases, stroke volume was calculated using a modified Kubitschek formula. We observed significant quantitative difference between the methods for stroke volume up to 33 millimeters and for cardiac output over 4 liters per minute. This shows that the choice of signal analysis method strongly affects the estimated hemodynamic parameters, and we conclude that methodological standardization and future validation are necessary for ICG to become a reliable tool in clinical practice. Thank you very much.
Good morning. My name is Ewelina Sobotnicka. I represent Łukasiewicz Research Network, Kraków Institute of Technology. Today, I would like to tell you about our review of AI systems that support doctors. AI is changing healthcare fast. It helps with diagnosis, treatment, and monitoring patients. But for real use, it also needs to be clear, trust, and fit well with hospital systems. In our review, we looked at what works best, what challenges exist, and how to use AI safely in practice. Our aim was simple, to show that the latest trends and useful practice that can guide future research and help hospitals use AI safely. Next, about our methods. We searched the DBLP database for AI in medicine systems. After filtering and checking access, we ended up with 11 papers to analyze. We look at their goals, technologies, and results, and group them into 4 main topics: clinical decision supports, machine learning and large language models, human interaction and trust, and explainability and data quality. This gives us a clear picture of how AI is used in healthcare and what challenges remain. Our main results in short. AI helps with the diagnosis, treatment, research, and doctor-AI interactions. Large language models and machine learning are shaping full clinical decision supports. But challenges remain. Lack of clear strategies, need for good data, and systems that are easier to understand. So success with AI in medicine needs trust, transparency, and teamwork. Thank you very much.
Thank you very much. And the next speaker is Ms. Maria Hankus.
Good morning, everyone. Ladies and gentlemen, my name is Maria Hankus, and I'm a student at the Faculty of Biomedical Engineering at the Silesian University of Technology. And today I would like to give you a brief overview on my engineering thesis focused on knee motion and effects of knee braces. Knee braces are widely used in clinical practice to support and stabilize knee joint. Despite their many benefits, they alter gait patterns and spatiotemporal parameters. The study investigated how different settings of an open knee joint brace affect GAIT, especially spatiotemporal parameters in healthy adults. The experiment involved 23 participants walking along a gait track under 3 conditions. The first condition was walking without the brace, so it was normal gait. The second one was walking with brace with deflection limited to 60 degrees. And the third one was also walking with knee brace with the knee flexion limited to 30 degrees. The kinematic and spatiotemporal data was recorded using Noraxon Ultium motion system and the Zebris FDM3 platform, and then the data was analyzed using MATLAB environment and Excel. The results indicated that restricting knee motion significantly changes gait. Step length, stride length, gait speed, and step frequency decreased, while step and stride time increased. Greater limitation also contributed to higher asymmetry between the lower limbs. This finding suggests that even in healthy individuals, restricting knee mobility with brace can noticeably affect walking patterns, and such insights may help in designing braces that support the knee function while effectively minimizing negative impact on gait. Thank you for your attention.
It's time for the next speaker, who is Joanna Lenart.
Good morning, everyone. My name is Joanna Lenart, and I represent AGH University in Kraków. Today, I would like to present our research on sex and region-specific differentiation in pelvic bone structures, and analyze through X-ray images. As people get older, bones lose mineral density. This makes them weaker and increase the risk of osteoporosis. This process is different in women and men. In women, it becomes much faster after menopause, while in men it's slower and more gradual. Their study was to analyze the differences related to age and sex in relation. We analyzed 684 pelvic X-ray images from 364 patients. For each image, we select 7 pairs of regions, which were proceeded with image enhancement techniques. Texture features were then calculated with QMaster softwares, and the results were compared with left and right sides. Finally, we performed statistical analysis to explore how these features can relate to sex and age and asymmetry. The results show clear differences related to sex and region of pelvis. In men, the highest correlation was found in the upper femoral shaft, and in women, the highest value appeared in the same region on the left side, and also in the greater trochanter. And as noticeable, left-right asymmetry was observed stronger in men than in women. And after image enhancement, the results were even clearer. For example, in the upper femoral shaft, the coloration increased from 0.5 to 0.61 after processing. In conclusion, texture analysis can reveal bone changes and may support early osteoporosis detection. Thank you so much for your attention.
Thank you very much. I'm pleased to welcome our next speaker, Ms. Olivia Skrzydłowska.
Good morning, everyone. My name is Olivia Skrzydłowska, and today I'd like to present our work named LME-based modeling of age and place of articulation effects on the production of the Ż consonant in preschool children. And as you can see, today I would like to focus on sibilants, so sounds such as syzycydy, sizycydy, or szyzycydy, which play an essential role in the Polish language. And those are typically acquired late and are often getting substituted. And those substitutions can vary depending on the precise tongue-palate contact called place of articulation, or POA in short. And we focused in our study only on the phoneme Ż, which is the voiced fricative. And we examined 3 articulation classes, which were the largest one in our data set. And the alveolar one considered normative, and 2 misarticulations, dental and postalveolar. And our aim of this study was really simple. We wanted to use statistical modeling to determine which of the acoustic features extracted can robustly differentiate between those POAs. And thereby, we would like to support the SLP's diagnostics. And moving to our methodology, we analyzed data collected from 178 children aged from 4 to 8. And the largest group was the alveolar one, consisting of 119 speakers. And when it comes to post-alveolar and dental production, it was 31 and 28 speakers respectively. And firstly, from the recordings, we manually segmented the phoneme Ż. And then each of those sounds we divided into 20 millisecond frames with 10 millisecond overlap, resulting in nearly 30,000 frames in total. And then from each of those frames, we extracted 48 acoustic features describing the voiced fricative noise characteristics. And when it comes to my favorite part, the statistical modeling, it was based on the linear mixed effects models, called LMEs in short, we were modeling each of those features using POA as our fixed effect, but we also incorporated random structure, and it was H, the surrounding phones, and the consonant position, and that was to attend for our interspeaker and lexical variability. And all of those analyses were performed in R using the alpha level equal to 0.05. And when it comes to our results, our proposed model structure was a good fit for 28 of our features, and we determined it with assessing the residuals versus fitted scatter plots, which has shown no systematic dependencies. And our alveolar class was set as an intercept, so as a baseline. And out of those well-fitted features, 14 significantly differentiated dental and alveolar productions, but only 4 differentiated significantly post-alveolar and alveolar realizations. And as we can see in the table, the noise energy group had the strongest class separability abilities. And, but we also should mention the FFRs, called fricative performance ratios, and because they also contributed meaningfully. And when it comes to our conclusions, the LME models the LME models are proved to be effective in identifying the acoustic correlations with POA. And unlike many machine learning models, which prioritize the predictive accuracy over interpretability of the results, LME models allow us to understand why those articulatory differences occur, and making them both statistically valid and clinically meaningful. And that would be it from me today. Thank you very much for listening.
Our next speaker is absent, therefore I would like to introduce Magdalena.
Ladies and gentlemen, it is my pleasure to present our research for you. My name is Magdalena Krycha, and I am a student of University of Silesia in Katowice in speech-language pathology. Today I am speaking on behalf of our team. To begin with, our Polish language contains 12 consonant sibilants, which are, as you can see on the screen, SZCZ, SIZI, and SZCZ sounds. So this pronunciation can be difficult for children in preschool age, and the total acquisition of those sounds can be around 6 or 7 years of age. So for the speech diagnosis, it is crucial to understand how exactly those acoustic patterns change over time. However, there is a lack of research in that topic. So in our actual study, we collect the data every 6 months, every measurement session, and our protocol combines picture naming test, hearing, phonemic hearing assessment, and also, last but not least, the physical hearing examination. We capture the child's speech sounds with cameras and also audio channels attached to the special child-friendly helmet, which is designed by our team. So during the first months of data collection, we faced some challenges, and we also found many solutions. Although the helmet was adjustable, we also captured some displacement of this helmet because of different head sizes of participants. So we introduced smaller helmet models, and also we added reference lines on the video feed. We also made the cameras adjustable. Another problem was the children's tendency to distract because of the equipment around. So as you can see on the photo, we provided some toys for them to help them to concentrate. Moreover, we are not able to entirely control the acoustic surroundings because we do the research in kindergartens. But there are many different solutions that we try to introduce. And this is just the beginning of our research, but we are working on future results. And those results and the whole data set will be a subject of detailed analysis and also statistical modeling concerning transitional articulation patterns. And this will contribute to the also theoretical understanding of sibilant development and practical applications in computer-assisted objective speech diagnosis. Thank you very much for your attention.
Good morning, everyone. I'm Luca Manassero. I'm a veterinary doctor in the University of Turin in Italy. In this poster, we work together with the Department of Biomedical Engineering in here, and also Cabiomed company. Angular limb deformities in dogs are a complex group of pathology that nowadays are treated with the aid of technology, so with the aid of some custom surgical guides. These guides are 3D printed, and normally they consist of 2 guides. The first one is to replicate the osteotomy, so the cutting of the bone, while the second one is for realignment of the bone. However, there is a problem because we designed these guides based on CT and based on the virtual surgical planning. While in the operating room, there is something different. We have a lot of variables, and one of them is for sure soft tissue tension. So the aim of the study was to engineer and reimagine a new step 2 guide that enables the surgeon to have more control to the procedure. So on the top you can see a step 1 guide. Traditionally is made of this guide that is fitting perfectly the bone, and then you have 2 planes that indicates the surgeon the cutting. So you take out the wedge of the osteotomy, and then beneath it we can see a step 2 guide that realign the, let's say, normal anatomy of the bone. But as you can see, this guide is a unique piece, so it's pretty difficult to fit on the bone. And we start to reimagine this guide by splitting in half, so it will be more easy to use. Adding also some clearance to it to give the surgeon some control in the compression, but we need also to think in something that keeps together these 2 pieces. And after several design, we end with a mechanism, an interlocking mechanism that can perfectly fit the 2 parts of the guide and give the surgeon a good control in the procedure before the fixation of the bone. In conclusion, we use this guide in a couple of cases, and we get some pretty good feedback from the surgeon because the procedures the workflow is similar, and in the future we will focus on more surgical testing to have more feedbacks, and also some quantitative bench compared to traditional one. Thank you.
Thank you very much for the presentation. And the next speaker is Wojciech.
The audience, my name is Wojtek Pieniążek, and I'm student of Biomedical Engineering at Silesian University of Technology Biomedical Engineering Faculty. And today I would like to share with you the results on our research regarding the detection of stigmatism in children's speech using mass spectrograms and convolutional neural networks. So stigmatism is this commonly occurring speech disorder that manifests itself through incorrect place of articulation of sibilant sounds, and one of such sibilant sounds is Polish affricate ch, as in the word taczka, and this affricate was the main topic of our study. And one of the key factors that determine the effectiveness of stigmatism therapy, especially in children in preschool age when the stigmatism most commonly occurs, is early diagnosis. However, due to the limited amount of speech-language pathologies, such early screening is not always possible. So to address this issue, we determined to explore how deep learning algorithms, particularly convolutional neural networks, can help in such speech diagnosis. And to achieve this, we need to transform our audio signals into graphical representations, and we decided to choose MEL spectrograms as a form of spectral representation. And the main difference between typical spectrogram that is commonly used in such applications and MEL spectrograms is the incorporation of not linear frequency MEL scale, which mimics human auditory perception by expanding low frequency while compressing high ones. It works mainly due to the fact that human ears are better at distinguishing differences between low frequency than between high ones. And you can see one of the MEL spectrograms actually on the screen right now. It is a part of Word Kaczka, I believe. The key parameters that influence the look of those MEL spectrograms and thus the effectiveness of CNN performance are the number of triangular filters applied and the window size length. And to research how those parameters affect CNNs, we incorporated pre-trained AlexNet architecture and used fine-tuning techniques with dataset collected by acquisition device you can see on the screen right now. Our dataset consisted of 152 children aged 5 to 6, and each pronunciation was reference classified by speech therapists. We trained 12 separate models with differing window lengths, 10, 15, 20, and 30, and with differing numbers of MEL filter banks, 40, 60, and 128. Our best model achieved a detection sensitivity of 80% with 40 filter banks and 15 milliseconds of window length. We can see slight tendency that with less filter banks, the models tend to perform slightly better. However, these differences were not significant statistically, and similarly, varying window lengths did not substantially influence overall model performance. So in conclusion, the MEL spectrograms can be effectively used in computer-assisted speech diagnosis. However, their parameters have not a significant impact in this particular classification task. Thank you for your attention.
And let me introduce the next speaker, Ms. Maria.
Okay, so ladies and gentlemen, it is a pleasure to present our work on automatic recognition of sign language. Deaf and hard of hearing individuals still face communication problems in daily lives. Even though sign language interpreters are more common today, the access is still limited. And this is why automatic recognition of sign language is really an exciting direction. With machine learning, especially neural networks, we can train systems to understand gestures and support real-time interaction as well as education. So in this project, our aim was to create and also test an application that can automatically recognize sign language digits with machine learning methods. Okay, so we base our work on two publicly available datasets containing images of American Sign Language digits. Altogether, that gave us 6,500 images from 13 people. And to evaluate performance under different circumstances, we designed 6 test scenarios that varied in background, hand orientation, and also the perspective. For classification, we use 3 different models: AlexNet, ResNet-18, and the SVM, so Super Vector Machine. And we decided to integrate these models into our application, which allows the user to upload the image or capture the picture from the computer camera, then select the model and simply immediately see the predicted digit. The experiment showed that convolutional neural networks achieve the best performance. AlexNet and ResNet-18 offer almost perfect accuracy. particularly for images from the computer camera. ResNet 18 proved slightly more stable across different scenarios, while AlexNet was almost flawless on this simple background. And on the other hand, the support vector machine produced much more variable results from as low as 30% to even above 90%, depending on the test set. And overall, the most challenging condition was a non-uniform background, where all of the models achieved a drop in accuracy up to 20 percentage points. But to sum up, our study confirmed that pre-trained convolutional models are effective in recognizing sign language digits, and such tools have the potential to support communication, to reduce barriers, and contribute to greater inclusivity for deaf and hard of hearing individuals. And thank you very much.
For the next presentation, we have two speakers, Ms. Ewelina and Ilona Karpiel. The floor is yours.
Good morning, my name is Mirella Kluza and here's Ewelina. We are students at Silesian University of Technology, the Faculty of Biomedical Engineering, and we would like to present you our research focused on computerized morphometric analysis of ovarian cancer cells. Epithelial ovarian cancer is the most common type of malignant ovarian tumor and one of the leading causes of cancer-related death in women. Most cases are diagnosed at advanced stages, which limits treatment success. BRCA1 and BRCA2 mutations not only increase cancer risk, but also affect tumor morphology and nuclear structure. Understanding these differences may help identify new biomarkers and improve early detection. Our goal was to determine whether nuclear morphometric features computed on a patient level can distinguish BRCA mutated from non-BRCA ovarian cancer cells. Detecting such differences could support genetic testing and personalized therapies.
So for our research, we used 870 hematoxylin and eosin histological images, which were provided from Cedars-Sinai Medical Center. And from this, 29 were patients of BRCA mutated, and 38 were patients with non-BRCA mutated. The pipeline begins with the color deconvolution of the histological images into 3 grayscale channels. Some preprocessing of cancer masks, which were obtained from STARDIST model, they were converted into binary masks. Then the filtering of nuclei from the cancerous masks was done using the centroid method. The obtained nuclear cancer masks were then applied to either one of the channels of the deconvoluted decomposition, and the labeling of nuclei was made. We managed to extract 20 morphometric features in total, including here solidity, elongation, eccentricity, compactness, major axis length, minor to major axis ratio, etc. Firstly, we calculated the mean value of each image, and then we aggregated the patients and calculated the mean value of each feature for each patient. And I would say this is the novelty of the research, because the other research take into the consideration the mean value of each feature without taking into consideration the patients. So the features are actually here represented by patients rather than just images. And then statistical analysis of these features, of these mean values, was conducted using the Wilcoxon rank sum tests in order to find the statistically significant different features between the two groups, as well as the Spearman correlation analysis between the features. The results. The results, actually, out of the 20 extracted features that were computed, 6 of them were found to have
to be statistically significant, different, and we can include here the major axis length, eccentricity, circularity, extent, elongation, with the most significant differentiator being the minor to major axis rotation. As for the Spearman correlation analysis, the heat map actually indicate a shift in the correlation strengths between BRCA patients and non-BRCA mutated patients. Well, in BRCA, the moderate correlation strength they are shifted into strong correlations into non-BRCA, and the mild ones are shifted into moderate into non-BRCA. But this cannot be a definite differentiator between BRCA and non-BRCA because it is because of the patient size disparity. As I said, we had 29 for BRCA mutated patients and 38 for non-BRCA mutated patients. However, mild correlations such as area and bounding box, actually the y-coordinate of bounding box, perimeter and the y-coordinate of bounding box, minor axis length and elongation correlations were found in the BRCA, which may serve as a differentiator from the non-BRCA patients.
To conclude, the results show that computerized morphometric analysis can effectively separate the BRCA mutated from non-BRCA cases. It shows promise as a fast pre-screening tool for genetic testing and highlights the potential of nuclear features as biomarkers for personalized treatment planning. Thank you.
Thank you very much. And I'm pleased to introduce the next speaker, who is Ilona.
So good morning, everyone. My name is Ilona Czajkowska, and today I would like to refer to the topic titled Evaluating Anatomical Risk Factors for Complications in Bilateral Sagittal Split Osteotomy. BSSO is a standard orthognathic surgery technique used for mandibular repositioning. During this procedure, the mandible is cut at 2 levels, and then chisels are used to separate the proximal and distal segments. The aim of the study was to evaluate anatomical risk factors associated with bad splits, so an uncontrolled mandibular fracture during the splitting phase. And the analysis was based on morphometric measurements based on CT scans. The data was collected from 13 patients, and the CT scans were performed pre and after the surgery. All of the surgeries were performed by the same surgeon, and the CT scans were used to obtain 3D models of the bones, and after that there were these measurements performed based on anatomical points, but not only. The fractures were classified according to the lingual split scale, and this is a classification which categorized the fracture pattern based on the location of the fracture according to lingual cortex. In this classification, the fourth type describes the uncontrolled mandible fracture, so it includes the bad split. And the number of bad splits that occurred here in this situation was 14. Bad split occurred 8 on the left side in 8 cases, and on the right side in 6 cases. And the analyzed factors were gender, age, presence of third molars, the thickness of ramus, the distance from mandibular canal to buccal cortex, and the type of the procedure. And the performed tasks allow us to gather information about the anatomy of the mandibles, but there is a need to perform similar tasks on patients who did not have the bad split to assess the risk of bad split and enhance the surgical safety. Thank you very much for your attention.
Hello everyone, my name is Mateusz Janecki. I'm a PhD student at Silesian University of Technology, and today I would like to show you how our brains see the 2 and 3 dimensions. So imagine watching the same movie on a flat screen versus stepping right inside. That's the difference between 2D and virtual reality. VR is now widely used in many research and therapy, but we still don't fully understand how our brain activates while seeing 3D images compared to 2D ones. So in our study, we tested how the brain's visual area react while we watch the same flickering checkboard on a flat screen and through VR headset. Our goal was to see if 3D activates brain more. So we invited 25 healthy volunteers. First, they watched the flickering checkboard on a screen, and then the same flickering checkboard on VR headset. While they watched, we used FNIRS. FNIRS is a safe method based on infrared light, which allow us to see the level of oxygen and the oxygen blood. More oxygen means more activity. So we measure how high the response was, how fast it appeared, how long it lasted. The results were clear. 3D activates brain more than 2D. The level was higher, the response was stronger, but the time was the same. It means the brain reacts as fast but more powerful when it sees 3D. So in short, VR doesn't just look engaging, it truly activates brain more strongly, and this finding can help us to develop better VR tools for learning, research, and also therapy, such as stroke therapy. Thank you very much for your attention.
Okay, it's time for the next presentation, and it also will be given by a pair of presenters, Dawid Rzeszowski and Marta.
Good morning, everybody. My name is Dawid Rzeszowski, and with me is Marta Polewka. We are the 5th semester students on biomedical engineering at the Silesian University of Technology. And today we would like to present a work of our team on database of facial movement for rehabilitation assessment using a market-based objective analysis system. So, patients suffering from conditions associated with facial dysfunctions frequently report difficulty in accessing professional rehabilitation equipment. This issue mainly affects those who undergo the oncological, reconstructive, plastic, and aesthetic treatments, as well as those with genetic disorders or neurological diseases. Currently, there is no ready-made solution for computer-aided facial rehabilitation system available on the market. The goal of this research is to collect a database of pediatric patients, developing a dedicated measuring system and examination protocol. The solution developed at this stage will constitute the foundation for further development of M4FT system, enabling automatic assessment of quality and range of facial movements and their application in patient therapy in the future. Data was collected by video recording each pediatric patient while performing 10 standardized facial exercises, for example, pouting or puffing cheeks. 17 ARUCO markers were attached to anatomical landmarks of each patient, with one marker on the forehead as a reference. In total, 133 videos were collected, and for every exercise, the physiotherapist provided an expert diagnosis about presence of facial symmetry issues.
After post-processing and visualization, we are getting 3D trajectories traced in time on the z-axis and centroid position on the xy plane. From the processed data, we created heat maps showing 3 things: how often a position was reached, how fast the movement was, and how long the patient stayed in one place. These outputs also allowed us to calculate symmetry, amplitude, and path lengths of movements. Conclusion. We were able to develop a measurement system and methodology for tracking facial movement using ARUCO markers. The established database provides a robust foundation for a facial movement analysis, distinguishing between normative and pathological motion patterns. Insights gained from this study contribute to the development of facial movement norms, which can support clinical assessments and rehabilitation process. Thank you for your attention.
Good morning, ladies and gentlemen. My name is Jakub Wężowicz, and I am student member of Student Scientific Club Biokreatywni. I would like to present our project we called USG Ergo. This is a mobile device supporting the ergonomics of physicians during performing ultrasound examinations. The project has been conducted in cooperation with Department of Diagnostic Imaging and Interventional Radiology from Medical University of Silesia in Katowice and Faculty of Biomedical Engineering from Silesia University of Technology. As many of you know, physicians who actively perform ultrasound diagnostic often suffer from spine disorders. In response to this problem, our team developed mobile device designed to relieve upper body of sonographers during the examinations. The goal was to improve comfort and reduce physical strain while maintaining full freedom of movement. The design process was carried out in Autodesk Inventor Professional. Based on physician's input, we prepared the geometry and functional concept of the device. The first prototype was then manufactured and evaluated in laboratory conditions, simulating ultrasound examinations. And here we are. It's the biggest element. It's a crossbar mounted on couch legs. A movable vertical section slides along the crossbar. The both two parts have adjustable length. At the end, a spring mechanism support provides stable assistance. And the most important part, a spring mechanism, allows natural movement with a stable body support. So the operator can reach even the most distant part of the patient's body. In the future, we plan to improve the functionality and design and conduct ergonomic and biomechanical studies with ultrasound operators. Thank you for your attention.
Good morning, everyone. My name is Łukasz Jałowiecki, and I would like to present our study, which is called How Backhand Technique Shapes Upper Limb Muscle Activity in Tennis. The aim of the study was to assess a biomechanical assessment of upper limb muscle activity in tennis in specific types of backhand stroke, which was the single-handed or the one-handed backhand, two-handed backhand, and the backhand slice. To make it clear for everyone, we've got two specific basic strokes in tennis. The first is forehand, and we made it from the side of our dominant hand. If we're right-handed, we make it from the right. And the backhand is the other one when we want to to hit the ball from the side of our non-dominant limb, so from the left this time. Moving to materials and methods, we've got 10 participants. All of them were active tennis players. And first of all, we made an interview with participants. Then we prepared them for testing. We had to attach electrodes to specific places on the skin. On the right side, you can see the specific muscles we mentioned in the study. That was both biceps and triceps brachii, and both wrist muscles, the flexor and extensor. We made an experiment by preparing the tennis players to perform a few strikes in each of the technique. Then we process the signal. We divide signal into 3 parts to make actually three phases of the stroke: the preparation, the acceleration, and the follow-through phase. Moving to results, in the preparation phase, we found out that in the one-handed backhand, the arm muscles are not required to generate substantial force, as their function is primarily stabilizing. In contrast, the wrist muscles position the racket on the appropriate angle and orientation, which accounts for their higher level of activity. In the acceleration phase, in the one-handed backhand, due to the absence of support of the other limb, during the stroke phase, greater activity is observed in the triceps brachii and the flexor. And follow-through phase, that's the phase after the contact with the ball, and the high activity was observed in the extensor carpi radialis due to the specific movement of the wrist, which is the wrist is going up after we hit the ball. And to conclude, results provide valuable insight into the biomechanics of different backhand techniques, highlighting the variations in muscle activation across stroke phases. The findings may serve as a foundation for future research and offer practical guidance for coaches and athletes, not only the experienced one, but also the young players that are looking forward to be the best tennis players. Thank you very much for your attention.
The presentation will be given by Ewelina Sobotnicka.
Good morning again. I will now present the results of the work of Michał Grzegorz Nowak, who couldn't not be here today. Our study focused on coating used on ablation electrodes. We know that the material surface, its shapes, textures, and chemistry affect how strong and durable it is. To improve these properties, we often add coatings like aluminum oxide. In our work, we studied steel, copper, and aluminum surface, both with and without this coating, to see how it changes surface, roughness, structures, and composition. Our goal was to understand how the coating improves performance and protection of different materials. We use SEM to take pictures of the surface, and it is to see what elements were there. For copper, we also looked closer with higher magnification. Surface roughness and shape were measured with a 3D optical polyphotometers. We focused on average roughness and maximum highest. The goal was to understand the surface structures, uniformity, and how the aluminum oxide coating changed the materials. Steel had granular structures with scratches and grooves. Copper was smooth with some scratches and the lowest roughness. Aluminium had parallel grooves, minor scratches, and the highest roughness. The aluminium oxide coating create a uniform and stable layer, keeping the surface clean and improving chemical purity, which changed the performance of all these materials. Thank you very much for attention.
Good morning, everyone. I hope I'm very well sound here. Today, it's an honor to be here and to present our startup, which is a spin-off of research at HGH University of Kraków. This is my team. I'm very proud to present them, the real engineers, the real minds that are working on this product, because we want to make some innovation. And now I give the word to Ewelina, who will present our sensor.
Good morning, everyone. I'm proud to present the microbial purity sensor integrated with AI application to detect microbial content in the air. Our team is called Micropura. Have you ever wondered how many bacteria or other microorganisms are in the air? I can assure you that in this very room there are more than people listening to me right now. Unfortunately, due to their miniature sizing, they're undetectable to the naked eye. So we are not aware if they are harmful or just the positive bacteria. Standard methods are really complex and usually require professionals to do it. Plus, they need a lot of time for results, and they are quite costly. Our goal is to provide society with the cheaper solution that they can use at their homes and see the results in a couple of minutes. Okay, thank you. So this is the Micropura. We have it here right now. We have the prototype. So our project combines microbiology and engineering with AI analysis and traditional image processing. We have filters with 4 media we have for media for fungi, for bacteria, for human pathogens, and for microbiome that we can detect if those microbes are really harmful or just positive bacteria living around us. We still need bacteria. We don't need to eradicate all of them. So the sensor will collect the air, sucking the air to the petri dish, and then the incubation process starts. We uncover what is not visible by growing the bacteria. And the sensor has also a camera that sends images to our virtual laboratory, where the traditional methods like image processing, segmentations are performed. Also, the high spectral image analysis is also performed. And with those data and results from a laboratory, which species is on the photo, we train our AI networks. Excuse me. We done citizen science project during the KGH Space Resources Conference at AGH. And we also are a part of Access Accelerator, where this startup is going into life, and those results will be displayed on the iPhone, on the other phones of the user. So the user will have the analysis done by our virtual laboratory in their phones. We have several publications about this. If you want to know more about this, you want more details, if you are interested, you can reach out. We are still here and will be today for the whole day. And our goal and our true mission is to detect microbial weather around the world, when we can prevent spread of diseases, spread of pandemics, and monitor the microbiome of the earth. Thank you.
It brings our session to the end. I would like to thank you for your attention and especially thank our young researchers for the effort, passion, and great presentation. I wish you a lot of success in the future work and a lot of fun in your research journey. Thank you very much.